Thursday, 6:12 a.m. A 54-year-old school bus driver sits on a hospital bed, dry-mouthed, touching his bowel surgery marker, awaiting anesthesia. That surgical robot is not autonomous. Soft tissue keeps changing shape faster than human hands can stitch it consistently. Da Vinci is teleoperated, every movement surgeon-controlled, with zero autonomous decisions or tissue tracking. In 3 hours, 2 soft, wet, moving ends of intestine must become one sealed tube. More than 1 million anastomoses, bowel reconnections, are performed in America yearly, roughly 2 every minute. In high-risk gastrointestinal operations, leaks reach 22.7%, and mortality among leak patients reached 22.2%, both about 1 in 5. Bacteria and digestive fluid can flood the abdomen, causing sepsis, another operation, or death. Johns Hopkins researchers built STAR, the smart tissue autonomous robot. Unlike Da Vinci's precision joysticks, STAR combines a depth camera that projects a light pattern with software trained to predict where tissue moves. But first, the enemy. The question is narrow. Can a machine make every stitch equally deep, spaced, and tight, while living bowel shifts beneath it, and recognize when its own plan fails? That seam, not the robot's appearance, decides whether our driver heals. So, too, sweatshirt sleeves, while someone twists them, now make them slippery, alive, easily bruised. Bone gives robots a fixed map. Intestine behaves like a shifting hammock. The task is intestinal anastomosis, joining bowel ends. Every needle bite needs equal depth, spacing, and tension. Too loose, it leaks. Too tight, tissue loses blood. STAR's endoscope projects structured light, a measured grid, onto tissue, building a moving three-dimensional map accurate to 500 micrometers, about half a millimeter. Machine learning software tracks deformation and predicts motion, closing a loop. See, plan, stitch, check. But the abdominal wall becomes a pivot, the fulcrum effect. Outside movement reverses inside, while wall pressure contaminates force readings. A spring and damper tissue model separates those forces. That is when the target moved, and STAR followed. STAR became first to perform laparoscopic, through small abdominal ports, intestinal anastomosis, autonomously in live pigs. Across 4 animals, it produced significantly better results than expert humans doing the same task. More uniform spacing and tension. The machine was not merely steadier. Under controlled conditions, it built a mechanically superior seam in tissue moving with breath. Civilization X follows the real numbers and engineering constraints. Stay with this seam. Because controlled success is not clinical trust. How? Reinforcement learning. Practice by reward and penalty. Let simulated robots attempt thousands of needle paths before touching tissue. Force-aware control then measures resistance. Compared with vision-only policies, it succeeded 3 times as often and pressed 62% less, like loosening a crushing grip. When STAR dropped a needle, it detected the mistake, revised its plan, and recovered without human intervention. Another sensor, optical coherence tomography, a microscopic depth scanner using reflected light, is being integrated to classify tissue and catch missed stitches beneath the surface. But STAR is slower than a human. Safety checks outrank speed, and speed is not the dangerous part. Now erase the camera view with blood. The constraint is real. The data exists. Whether the systems built around it can act on it at scale, that is the next engineering problem.